Thank you for joining us today. My name is Janik Goryev, and I'm the Health Information Specialist with Brain Tumor Foundation of Canada. Today we have Dr. Gerald Lim from the Tom Baker Cancer Centre in Calgary, Alberta. Dr. Lim completed medical school in 2002 at the University of Alberta and did his residency training at the Tom Baker Cancer Centre in Calgary from 2002 to 2007. He completed a one-year fellowship at the Princess Margaret Hospital in Toronto from 2007 to 2008, where he trained in image-guided radiotherapy for lung cancer. Dr. Lim joined the Tom Baker Cancer Centre team in 2008, and his current areas of specialty are CNS and lung cancers, and he is also co-lead of the Alberta Radiosurgery program. Today, Dr. Lim's presentation will focus on meningiomas, and thank you for joining us today, Dr. Lim, and I'll hand it over to you.
Thank you, Janik. So thank you again, Janik, and the Brain Tumor Foundation for giving me this opportunity to speak. Today I'm going to talk about meningiomas. And here is a roadmap of some of the things I'm going to cover. So I'm going to go through some background on what meningiomas are, discuss some of the management options, and then go into some detail on radiotherapy. I'd like to talk about how it works and discuss some of the technology available and go through the process of radiosurgery itself. And then we'll have time at the end for questions and discussion as well. So to start, I am going to answer the question of what is a meningioma. It is a very diverse group of tumors. They are tumors that arise from the meninges, and the meninges are a membranous structure that surrounds the entire brain and cerebral and central nervous system. So thankfully, most of these tumors are benign, but in a small percentage of patients, they can be malignant or anaplastic. Here is some epidemiology on meningiomas. They occur at about a rate of 7 per 100,000 per year, and in the general population, it's about 97.5 per 100,000. And they are one of the most common primary brain tumors. So I'm not sure if people have heard a lot about meningiomas, but if you think about primary brain tumors, they're actually a very common primary brain tumor. Median age at diagnosis is a little bit older, middle to older, at 58. And again, there are three basic types of meningioma. Most of them, thankfully, are in the benign category, but some are anaplastic or malignant, and so those are very aggressive. And then there's a category in between the two called atypical. And the behavior of the atypical meningiomas can vary. Some behave a bit more like benign tumors, while others can be quite aggressive. Most of the benign tumors peak at around 60, 70, or 80 years old, whereas the malignant tumors tend to occur in younger patients. There is a female predilection, and so the female to male ratio, it's about 2 to 1. In some patients, about 3 to 8% of patients, the meningiomas occur all over the brain. So not just one tumor, but they occur in multiple sites. Most of the meningiomas are supratentorial. There is a membrane in the brain called the tentorium that separates the brain into an upper portion and a lower portion. And most meningiomas occur above this membrane. So about 15% are atypical and 10% are malignant, but the vast majority are benign. So what causes a meningioma? For the most part, no one really knows. I would say it's kind of bad luck, but one of the things that has been found in the past to definitively cause it is a history of radiation. This is the only clearly identifiable risk factor. Studies looking at this in the past have found that patients who were given radiation for other reasons, and this is many, many years ago, we would certainly never do this now, but patients given radiation for other reasons many, many years ago had almost a 10 times risk of developing these tumors in the brain. More recently, there have been studies to link dental x-rays with the development of meningiomas in the brain as well, although the risk in those instances was still very low. In order for something to be called radiation-induced, it has to occur within the radiated field, and obviously it could not have been there prior to the radiation. There must be some sort of latent interval, meaning that the tumors don't occur really quickly after treatment, but they take several years. So it could be 10 years or 20 years later before these tumors develop. Some other things that have been linked, although they're not causative of meningiomas, are parvovirus, breast cancer, neurofibromatosis, MEN1, so a lot of other conditions that have been linked to meningiomas. If you look under the microscope, that's what a meningioma would look like. They come from what we call arachnoid cap cells, and these are cells found at the arachnoid granulations. And these are areas in the brain where the cerebrospinal fluid is reabsorbed and returned into the venous system. If you look at it grossly, they are usually well circumscribed tumors. They are firm and they kind of look tan or grayish. They can also be lobulated and have blood vessels running through. There are many different types of histologic variants of meningiomas. So I've listed them here. A lot of the words are difficult to pronounce. Syncytial, transitional, fibrous, angioblastic is a whole long list. So if you were to ever look at a pathology report, you might see some of these terms. But ultimately, they don't matter so much as to how patients do or how we manage. So it doesn't really matter what histologic variant the meningioma is. What's most important is the grade. So there's little clinical value to these terms, but they're more for academic purposes. So the grade is the most important thing with respect to the meningioma. And when looking at the grade, the pathologist would look at the architecture of the cells, the cellularity, the nuclear pleomorphism, mitotic figures, necrosis, and whether there's been brain infiltration. Then they assign a score to the meningioma between 1 and 3. So a grade 1 meningioma would be considered a benign meningioma, very slow growing, unlikely to cause any, unlikely to kill anybody, slow growing, benign. A grade 3, on the other hand, is a very aggressive meningioma. It tends to grow back. Despite cutting it out, giving it radiation, it tends to grow back, and patients do die from grade 3 meningiomas. The grade 2 category is in between, and as I mentioned before, they are called atypical meningiomas. Some behave aggressively, some behave more benign, and the management for grade 2 is a little bit more controversial. So in terms of the natural history, symptoms are caused by the meningiomas growing and compressing the adjacent brain tissue. So a lot of times the symptoms would depend on where the meningioma is. I've listed some of the locations that meningiomas tend to grow. Most commonly, they grow on the parasagittal area of Falx, and this is a membrane in the middle of the brain. They can also grow in the cerebral convexities or the sphenoid wing. And as you can see, in the base of the brain is also a common area where they grow. Other areas outside the brain include the spine. So you can have meningiomas that grow in the spine or on the nerves of the eyes, the optic nerves. And this is just a diagram showing where some of the typical locations for meningiomas are. So parasagittal being the most common, right there. Convexity being the second most common. And then other areas. This area of the brain is called the posterior fossa. And you can have meningiomas growing there as well. So this is a typical picture of a meningioma. You can see it's grown fairly large. There's a little bit of swelling around it, this darker area in the brain. And this area here is called the fourth ventricle. It is compressed by the meningioma. Another picture from meningioma. This one looks a bit more nodular, and it's on the right frontal lobe of the brain. And here's another meningioma in a difficult to operate location. So meningiomas can grow into the brain or bone, and sometimes they can cause a reaction in the bone, which we call hyperostosis. So the bone will swell up because of the meningioma that's next to it. And if it swells up enough, you can even feel it as a lump on the skull. Tumors in the most common area, the parasagittal area, can invade and obstruct the big vein that runs on top of the brain. Meningiomas don't metastasize, so they're not like other cancers that spread to other parts of the body. They grow in the same area, but there are some other similar histologies like hemangioparasitomas that can actually spread to other areas. But in general, meningiomas do not spread, and the grade 3s, the malignant ones, they tend not to spread as well, but they just keep growing and growing and coming back. So the rate of growth depends a lot on the grade. The grade 1s, benign tumors, they grow very slowly over time. Grade 2s, they've got a variable growth rate, and the grade 3s are fast-growing and difficult to control. Other factors that can sometimes tell us how quickly these tumors are growing are patient's age or calcification, if we see calcification on the scans, or edema. Calcification would tend to suggest a slower growing tumor, whereas edema in the brain or swelling in the brain would suggest a faster growing tumor. Here are some prognostic factors for survival. Location of the lesion is important. There are certain locations where if it's hard to operate, it may have a worse impact on survival. The extent of resection is very important. A gross total resection gives the best outcomes, and gross total resection means that the surgeon has gone in and removed all the tumor that he could see. The grade is very important, benign being slow growing and having a very good prognosis, whereas malignant tumors would have a very poor prognosis. Age, KPS is the Karnofsky performance status, meaning that basically how fit and how well the patient is. So patients who are fitter and feeling better tend to do better overall. And the use of radiation has also been found to impact the control rates of meningioma, which is what I'm going to talk about later on. So treatment consists of several options. Observation is one option, depending on the grade of meningioma, the rate of growth. Surgery is another way of dealing with it. Radiation, which is my focus, can be used to control meningiomas. And chemotherapy, not so much, but I will briefly mention that at the end of the talk. And usually what happens is we use a combination of these different options to deal with meningiomas. Every situation is different, and so we have to tailor our management to the individual patient. So observation is a good option if it's a benign tumor, if it's slow growing, and especially if it's not causing any symptoms. It is not uncommon for these tumors to be picked up incidentally, meaning that a scan was done for some other reason and we so happen to find a benign meningioma. So in many of those cases, if it's not causing symptoms, it would be safe to watch these tumors. We can start off with scans every 6 months or so to try and determine the rate of growth. If the tumor appears to be fast growing or it's causing symptoms to patients, then we could consider treatment. For elderly patients with lots of comorbidities, with other medical issues, then the best approach might be to observe these tumors, even if a surgeon wasn't able to remove all of it. So surgery is an option. This is good in terms of addressing the tumor immediately. So if a patient is having symptoms, surgery would basically take those symptoms away right away. And we also have tissue confirmation, meaning we know exactly what it is. If we can go in and take the tumor out, then we'll know exactly what grade and exactly what it is. The goal is gross total resection, so try to remove all of the tumor. However, that is quite frequently not possible because of the location of the tumors being in critical areas or adjacent to critical structures. The surgeons may not be able to remove all of the tumor. Sometimes the tumors can be stuck to the big veins in the brain, and in those cases, again, some of the tumor will be left behind. Radiotherapy is an option. The goal is to control these tumors. So radiation does not remove the tumor, but it stops it from getting bigger. The advantages to radiation are that it is non-invasive. You're not undergoing actual surgery, and you've got low morbidity. The side effect profile for radiotherapy is very good. So when do we use radiation? We use it when surgery is not possible, when we see that a tumor is getting bigger. If the tumor is a malignant tumor or an atypical tumor, we will often recommend radiation after surgery. So for malignant tumors, even if the surgeon was able to get all of it out, our recommendation would be to do radiation to the surgical bed. If it is an atypical tumor, then as I mentioned before, the management is a bit more controversial. In Calgary, our practice is to offer radiation to these patients if the surgeon was not able to get all of it out. If the surgeon was able to get all of the atypical tumor out, then we would recommend observation after that. But because it's an atypical tumor, close observation would be necessary because the recurrence rate would be relatively high. So if the tumor is causing a lot of symptoms, then we would recommend surgery as opposed to radiation because, as I said, surgery would be able to relieve those symptoms right away, whereas radiation basically stops the tumor from getting bigger, and it doesn't alleviate urgent symptoms. How does radiation work? Radiation targets the nucleus of the cell. This is where the DNA is, and by causing DNA damage, we can kill the cancer cells, but we could also cause carcinogenesis or mutations in the cell. There are two ways that radiation acts to kill the cancer cells. Direct action, whereby atoms in the target or the DNA are directly ionized by the radiation, causing damage. But the bulk of the effect comes from the indirect action, where radiation interacts with other molecules in the cell, like water, to produce free radicals. And these free radicals then attack the DNA in the target cells to cause damage. So why is it that radiation can be used to kill cancer but not the patient? And the reason for that is what we call the therapeutic ratio. So this graph illustrates that. The line on the left represents tumor control. So for a particular dose of radiation, we, in this example, may be able to control 30% of the tumors. But for that same dose of radiation, we would only have about a 5% chance of causing normal tissue damage. So the ability of normal tissue to repair itself is much better than the ability of tumor tissue to repair itself. And so for the same dose of radiation, we cause a lot more damage to the tumor than we do to normal tissue. So today, there are lots of different radiation machines out there. These are some of the technologies available. The main workhorse in radiation treatment is the linear accelerator. Some of the older units would be things like the cobalt unit or the deep X-ray unit. And then some of the newer units are things like tomotherapy, gamma knife, CyberKnife, and proton therapy. And gamma knife and CyberKnife are units that we use to deliver radiosurgery. But we are also able to use the linear accelerator to do that. So technology today allows us to focus radiation very well. It allows us to use high energies of radiation to penetrate deep tissue while sparing the surface of the skin. The machines can rotate and come from many different angles. We can shape the radiation beam. We've got moving collimators, and we've got image guidance. We can even deliver radiation at certain times in the breathing cycle for tumors outside the brain. I wanted to just briefly go over the process of radiation after the clinic visit. So what happens after the clinic visit? We need to do anatomic localization. We call that simulation. Patients get a mapping scan. Then we fuse the MRI scan to the mapping scan, and that helps us to define the target. Once the target has been defined, we start planning. So that's where we start aiming the beams and coming up with a treatment plan. Then we need to do a lot of setup verification, and finally we deliver the treatment. So conventional radiotherapy. This is used to treat all grades of meningiomas, and terms that you may have heard or read about include 3D CRT, which is 3D conformal radiotherapy, or IMRT, intensity modulated radiotherapy. With conventional radiation treatments, we give small doses of radiation each day aimed at the tumor. Typically, it's between 25 to 33 sessions of radiation, depending on the type of tumor and the grade of tumor. So 3D conformal radiotherapy, radiation beams are angled at the tumor and they're shaped to fit the target. So planners actually point these beams and shape the beams. So it's forward planning. You look at the target and you decide how you want to plan things. This here is a diagram of a linear accelerator. These are the leaves of the collimator that help to shape the beam to conform to the target. Here's an illustration of how 3D conformal radiotherapy works. That's the target. We've got beams coming from 3 different sides. And where they all cross, that's where you get the highest dose of radiation. IMRT is intensity modulated radiotherapy. The beams can be static or dynamic. The leaves in those collimators move during treatment to modulate the intensity of the beam. And we call this inverse planning. Usually what the planners do is they define a set of criteria and let the software do some of the planning. So with IMRT, we can get better sculpting of the radiation dose to conform to the target and spare surrounding normal tissue. So this is particularly useful for tumors that are located in areas that need to, where you really need to spare surrounding critical structures. So here's an illustration for IMRT, where again, with the beams coming in from different sides, but we are modulating the beams. And the end result is something that looks like that. So we compare the two side by side. That's 3D conformal radiotherapy versus IMRT. That's the target with 3D that you would treat. Whereas with IMRT, we can shape the dose a lot better. So if there are any critical structures directly adjacent to the target, we would be able to spare those critical structures. This is an example of a IMRT plan. It looks rather complex. We've got multiple radiation beams coming in, treating the target right there. It's adjacent to critical structures. And in this box on the right here, this line that goes all across represents the dose delivered to the target. So it's a very high dose delivered to the target. All these other lines here represent the critical structures, and they have very little radiation dose getting to them. So stereotactic radiation. This is a different method of delivering radiation. With this method, we are able to treat small, well-defined targets with very high precision. We use multiple narrow radiation beams. We use immobilization and imaging devices or techniques to limit or monitor for any movement during treatment. And we are able, with this technique, to give very high doses of radiation over one or just a few treatments. And I wanted to clarify some of the terminology here. Radiotherapy versus radiosurgery. Radiotherapy refers to multiple treatments, whereas radiosurgery, it is radiation delivered in a single treatment. So stereotactic radiosurgery for the brain. We can use this to treat metastatic disease, tumors like pituitary tumors, craniopharyngiomas, and benign conditions like acoustic schwannomas, AVMs, and meningiomas. So radiosurgery is a single high-dose radiation delivered in just one session. Patients are immobilized with a head frame or a mask. Our current practice in Calgary to treat meningiomas is to use a head frame. That way we really limit any sort of movement. So with the head frame, we actually have to screw a metal frame into the skull. After we put some freezing, then that head frame can be attached to the treatment table to completely immobilize patients. With that, we can deliver the treatment with very high precision, within a millimeter precision. So some of the main technology out there to deliver radiosurgery include linear accelerator-based units, the GammaKnife unit, and the CyberKnife unit. And I think probably the most popular unit is the GammaKnife unit, because most of my patients come in asking about GammaKnife. And I sort of did a Google search to see how many hits, and it does appear that GammaKnife is the most popular unit out there, 700,000 hits if you Google radiosurgery GammaKnife. Linear accelerator-based units, there are multiple different types, but if you combine them, it's 400,000 hits, and CyberKnife at 20,000 hits. So this is an example of a linear accelerator-based unit, and this is what we use in Calgary. The machine rotates around the patient from different angles, and as it rotates, the radiation beam comes on. The collimators in the head of the machine shape the beam, and it goes around the patient in an arc. And typically it does that between 3, 4, or 5 times. So 3, 4, or 5 arcs around the patient. And where all those arcs cross, you get the highest point of radiation at the meningioma. This is another linear accelerator-based unit that's out there. It's called the EDGE. And here's a different unit called the Vero system. So they all deliver radiation. The goal is to try and come in from many different angles, to try and spread out the radiation, but concentrate the highest dose at a very specific point. And most of these machines come with lots of imaging devices as well to make sure that we're lining patients up in the correct position. The CyberKnife system is a little bit different. It's like a robotic arm. And so these slides are courtesy of Accelerator. The robotic arm rotates around a patient and basically can have multiple degrees of freedom, come in from any angle. It delivers a pinpoint beam of radiation, and where all those pinpoint beams cross is where you get the highest dose. This is the GammaKnife system, which I think most people probably have heard about. And this is a little bit different from the other systems in that it actually uses a radioactive source. So it uses a radioactive cobalt source in the machine. It's got lots of beamlets, I think about 200 beamlets. And here's an example of a radiosurgery plan. You can see the meningioma in this picture here. It's outlined in pink, and the radiation delivered is the dose in faint yellow. So the highest dose of radiation is delivered to the meningioma. It spares a lot of the surrounding brain, so the amount of radiation that goes to the rest of the brain is very minimal. All of it is concentrated in just this one spot. Here's another example. This tumor is in a really critical location. It's close to the optic nerves in the eye, the optic chiasm. And again, we're able to deliver very focused radiation at that one spot. This is just a different view to give you an example of what some of the planning software can look like. So radiosurgery has really good control rates. I would say it's in the order of about 90 to 100%. It has very low toxicity. It is dependent on the location of the meningioma, but in terms of causing permanent severe injury to the surrounding brain tissue and nerves, the risk is very low. All we need is a very small separation between the critical structures and the target in order to deliver radiosurgery. There are some other areas of the brain, like the pituitary gland. If it did get some radiation, you may need to be on hormone replacements several years down the road. A lot of these meningiomas may occur close to that target. In the parasagittal location, it is a bit unclear, but tumors in that location tend to cause a lot of swelling after treatment, and patients can get some temporary symptoms if there is a lot of swelling after these tumors are treated. There's also a small theoretical risk of developing a stroke or a cancer because of the radiation. You know, we're not able to really quantify what these risks are, but we know they're very small. And if I had to estimate a number, I would say the risk of developing cancer from radiation treatment is about 0.5% per 10 years. So extremely small theoretical risk. Here's another example of a tumor that was treated. So on the left was just before treatment, on the right is after treatment. Usually these tumors do not shrink a whole lot after treatment. They certainly do not disappear. The main purpose of radiation is to control the growth of the tumor. So oftentimes the tumor will still be there. It may be a little bit smaller, but it will always be there, except it will not grow again. And I put this up just to show an example of some swelling after treatment that can occur. So this area here is some swelling in the brain that can occur after treatment. But in many cases, it's temporary, and after a few months, the swelling goes away, and you're back with just a tumor that's been well controlled. So what about chemotherapy? Unfortunately, not a big role for chemotherapy in meningiomas. If you look in the literature, people have tried lots of different types of chemotherapy. I think the results have really not been very good. So chemotherapy generally, at least in Calgary, it's seldom ever given to treat these types of tumors. So to summarize, there are many different types of meningiomas, but the most important is the grade of meningiomas. Thankfully, most of them are benign. Most of them are grade 1 benign tumors, and those have very good prognosis and a very good chance of controlling those tumors. On the other extreme are the malignant tumors, which are very difficult to control. Those are treated with surgery and radiation, and despite all that, most of them will grow back. And then there's the in-between group called the atypicals, which, as the word describes, atypical. They can behave one way or another. Radiosurgery is a highly effective treatment for low-grade meningiomas. It's got a very good side effect profile, and all we need is a very small space between the target and the critical structures in order for us to deliver the treatment. We usually limit the size of the target to about 3 centimeters or less. So if the tumors are larger than 3 centimeters, then we may not recommend radiosurgery in those cases. There's lots of different technology out there, many different machines. Gamma knife is probably the one that most people have heard of, but there are many other different units, and they all are capable of delivering radiosurgery, and in my opinion, they're all equally effective. So I'm going to leave the time now for questions and discussion. If anyone has any personal experience or with this they'd like to share, or any questions about tumors.
Great.
Yeah.
Thanks so much, Dr. Lim. Great presentation. Lots of really, really great information. I know I learned some new things as well. We do have some questions that came through the chat area, so I'll just read those to you. One person had 2 parts to her question. The first part is, if you're not having symptoms that are bothersome, but it is a 1.7 centimeter meningioma compressing on your 7th and 8th nerve bundle, can you watch and wait? I'll give you that's the first part.
Okay.
I'll let you answer that first.
I'll have to think about that for a little bit. So
Sure.
It's a relatively small tumor, but it is compressing the cranial nerves. However, no symptoms.
Correct. If you're not having symptoms that are bothersome and it's compressing on the 7th and 8th nerve bundle, can you do a watch and wait?
I would say it's probably reasonable to watch and wait, but I would expect that a tumor that's already compressing those nerves will probably start to cause symptoms in the near future.
Okay. And sorry, go ahead.
Yeah, so once the tumor starts to cause symptoms, treating it with radiation may not reverse those symptoms at that point in time.
Okay. And so the second part of her question is also, can a meningioma in this location cause your neck to be slightly achy?
So hard for me to comment without looking at the actual scans and pictures, but I would say no. The meningioma compressing the 7th and 8th nerve may cause hearing problems, facial paralysis, but not likely to cause neck problems.
Okay, thank you. The next question is, there seems to be some controversy about control of meningiomas 10+ years after radiation. What do you tell your patients about control after 10 years?
So to be really honest, most of the literature out there does not report on control rates after 10 years. So the real answer would be we don't know. Now, I think it'd be reasonable for us to assume that if it's been controlled for that many years, it will continue to be controlled. But because most studies don't follow patients that long, we don't really know.
Okay. Thank you for answering that. And we've got lots of questions popping up here. It's great. If you have radiation and then become pregnant, is there a chance that pregnancy hormones will cause the tumor to grow again, or is the tumor quote-unquote dead regardless of hormones?
So some people think that meningiomas have estrogen receptors, and I think there's some physicians who recommend not taking estrogen or getting pregnant. I think this area probably needs a bit more research. I think if you've had it treated, you can probably go ahead and get pregnant. I don't think there's evidence to say one way or another, and I understand where a patient's coming from, and I understand the question. But again, I think it's an area that no one really knows.
Sure, that's valid. Thank you. And next question is an atypical tumor the same as a tumor in transition?
I have to say I haven't heard that term before, tumor in transition. Atypical tumors are grade 2 tumors, and I think in the talk I mentioned they can behave, some can behave like a benign tumor, some can be quite aggressive, so it's a bit unpredictable. The treatment for those are surgery. In Calgary, our practice is to do surgery, and then we follow that up with radiation if the surgeon wasn't able to get all the tumor out.
Okay. Thank you for that. And looks like we have 3 more questions. The next one is, how common are meningiomas for post-treatment medulloblastoma patients? Are you able to comment on that?
So relatively high. If you had medulloblastoma, you would have had radiation to the brain and the entire spine. And in that one study that looked at patients who had radiation for other reasons, there was a 10 times risk of developing meningiomas. So I don't know if anyone has specifically looked at medulloblastoma patients and developing meningiomas, but I would say that there's definitely a much higher risk of developing meningiomas, and it could be in the brain or throughout the spine because that's where the radiation would have been targeted. And at least from that one study, it was a 10 times risk.
Great. Thanks, Dr. Lim. All great questions and all great answers. Next one is, how frequent is post-radiation necrosis?
So with conventional radiation, it is very low. Even with radiosurgery, I would say that the risk is very low. I generally would say 5% or less. And even if you do get a little bit of necrosis, most of the time it does not actually lead to permanent symptoms. With radiosurgery, the targets are small, and we deliver the radiation very precisely. So the risk of radiation necrosis is low, and I would say 5% or less.
Okay, thank you. The next question is, she kind of has two parts to her question. It's the link between, or is there a link between meningiomas and breast cancer? So the first is, what is the chance of having a second meningioma after having a recurrence of breast cancer, and what is the relationship of breast cancer and meningioma?
So as I said, there is a relationship, but it's not, we don't know, we don't think it's causative. We don't think that if you have breast cancer that causes a meningioma. But somehow it does seem like patients with breast cancer do have a higher instance of meningioma, but we can't really say that one causes the other.
Okay. And sorry, a couple more questions have popped up here, so it's great. This topic is obviously a hot topic. So if a meningioma is calcified, does that mean it will never grow?
No, if it's calcified, that suggests that it's slower growing. Tumors in a body that grow slowly tend to get calcium deposits. So if it's slow growing, you tend to get calcium deposits. But it doesn't mean that it's not going to grow.
Okay. And looks like last question. What are your thoughts on radiation for patients under the age of 40?
When I see patients under the age of 40, it's always we always have to weigh the pros and cons of doing the treatment. Now, every situation is different, so I guess hard to generalize for a broad question like that, because it depends. If the tumor obviously is causing problems, then we should treat whatever the age. But if it's something that we can wait, then I tend to. Sorry, I can't comment without more detail on that.
Yeah, it's difficult. It's difficult for our physicians to answer specific medical questions without having, of course, the patient's file, the person's file in front of them. One more question did pop up. I'm not sure if you are able to comment on this or not, Dr. Lim. Person says that I have a benign posterior fossa meningioma and also have Meniere's disease, hearing loss, and tinnitus, and peripheral neuropathy. Does the meningioma affect this?
No, so posterior fossa could be the posterior fossa is still quite large. If it was next to the 7th or 8th nerve, then that could have potentially affected hearing, but I'm guessing it's probably not, so it probably would have no effect on the Meniere's disease or peripheral neuropathy.
Okay. Great, thank you. Looks like those are all the questions, and thank you again, Dr. Lim, for taking time out of your schedule and joining us today. Before we do end the webinar, I just wanted to switch the slides back over to me for a second here so I can show everybody some slides from my computer, just to let everybody know that we have some events coming up. So if you're in any of these areas, we have our Information Day conferences happening. We have a half-day pediatric session that's happening on Saturday, September 20th. That's coming up this weekend. We also have our full-day conferences in London on October 4th, in Calgary on October 18th, and Halifax on November 1st. And we also have some healthcare professional programs. So for those of you who are healthcare professionals, if you're in the London, Ontario area, we're hosting a breakfast symposium for healthcare professionals. It's a half-day session on October 4th. And then we also have our annual healthcare professional workshop in Calgary on Friday, October 17th. And this year we're trying something new for Halifax. For those of you in the Halifax area, we usually have a full-day conference for healthcare professionals on the Friday and then the info day on the Saturday. We've combined both events to happen on the Saturday. So in the morning, everybody will be in the same room for the plenary and the keynote and the panel, and in the afternoon there'll be concurrent sessions happening and 2 specific workshops specifically for healthcare professionals. Also new coming up this fall is that, as most of you know, we have our spring sprints in the springtime. We now have some brain tumor walks happening in the fall in Sudbury, Ontario, in North Bay, and in St. John's, Newfoundland. And all that information, of course, can be found on our website. And our next webinar is on October 15th with my lovely colleague Trishna Wedemeyer, who's our support services specialist, and she's going to be talking about the value of support, finding what works best for you. And also a reminder that Brain Tumor Awareness Month is in October, so watch for our website, watch our Twitter account, and our Facebook, and our YouTube pages. We have lots going on in October, and we'll have lots of events happening across the country. And if you do work in a hospital or at an organization and would like to do a display for us to help us create more awareness, please let us know. We'll get back to you with those details. So thank you again, Dr. Lim. Thank you, everybody, for joining us today. There was lots of questions, and if we didn't get to all your questions, I will follow up via email with Dr. Lim and with yourself. So thanks again.
Thank you.
Thanks, Dr. Lim.